Hi, I'm Dr. Janet Pope. Please join me at Room Now, and we're going to talk about to clot or not to clot. And this is with respect to rheumatic diseases. So I have with me from Brigham and Women's, Harvard, Dr. Jeff Sparks. So Jeff, wonderful to have you in Room Now again.
Always good to see you. Can't wait to be in person again.
Absolutely. That'll come someday. I think
Yeah,
next year. I'm
I
buying a
think
plane
so.
ticket. I am. I'm leaving. I'm coming. So I thought it would be interesting. There's a lot with the oral surveillance, but also
Mm,
knowing that rheumatic diseases and the whole JAKs as a class, I think it's a muddy watered area, but to clot or not. And I
mm,
mean, certainly an interesting abstract at this meeting was looking at PMR and GCA in the VA population, and they actually kind of look like a dose response that compared to OA, age and sex match populations, large and multi-site, that there was more clotting in GCA, arterial venous, and of course retinal, arterial and venous, then GCA plus PMR and the least amount in PMR, all of which were numerically and statistically higher than OA. So what do you think is going on there? And how does that maybe help us interpret all these other,
hmm
like, is it the drug, the disease, or both?
Well, I think other vasculitides have certainly been shown to have some clotting risk, and it makes sense. You got a blood vessel that's inflamed; it's going to probably have a more of a propensity to have clotting, both on the arterial and venous side. The PMR I think is novel, and certainly some of those might have some kind of subclinical vasculitis that might explain it. But we're seeing this across many rheumatic diseases. We're seeing it in RA with high disease state. We're seeing it in patients that are refractory to many medications. We're seeing it in patients that have risk factors for VTE. So it really does seem that systemic inflammation is really turning the tide towards there to have a propensity to clotting. And obviously, this is a big deal, particularly if there's agents, medications that are going to, you know, perhaps put people at even more risk. And that's the time when we're treating is when there's high disease activity and high systemic inflammation. So I think this is something that is going to be more in the forefront of rheumatologists' minds
Yep. And I think
across
there's
many diseases.
more exactly. And it was interesting you're saying maybe there's subclinical things going on in PMR to increase the risk. So there was an abstract as well at this meeting saying that there was more arteritis, large vessel, in patients that were supposed to just clinically have PMR, an imaging study. And I know last year at ULAR, earlier this year at ULAR, we covered something showing that there were a lot of PEs in patients with active Takayasu seen on PET scan, and we weren't sure of the clinical relevance. So yeah, I do think there's a dose response with the disease activity, probably with extensive disease in some of them. And I think we really won't know the answer yet on what is the magnitude of the risk of a certain drug or a certain class of drugs in decreasing clot risk, and in some instances, maybe increasing clot risk. So I think the story will unfold right here in Room Now over the next year or two.
Absolutely. Like Shakespeare, we'll, you can always get more information out of this. It's really complex. You think about, patients with arthritis and their mobility and obesity and diet, and there's a lot of different mechanisms to go after. Reproductive factors and certainly steroids, medications. So a lot to keep in mind. And then when this happens, it's obviously a big deal for everyone.
That's right. So we got to remember Virchow's triangle, that it's the host, the immobility or other factors, and then really piling up risk factors. So as you say, if someone's maybe on oral estrogen and smokes and has high blood pressure, but the biggest risk of clotting, of course, just like the biggest risk of erosions, biggest risk of clotting, to clot or not to clot, is having a clot before. The biggest
Yeah,
risk of joint damage in RA is having joint damage. So I think we have to know that the highest risk factor is they've already proven in their blood vessels they can have the event.
past
Great.
is prologue to keep it literary.
That's right.
But
Absolutely.
yeah, if they've had a history of clot, you really got to think hard about minimizing anything you can that might have them a propensity to clot more.
Great. Well, listen, follow us at Room Now, and we both, Jeff Sparks and myself, both have Twitter accounts. So we will keep you informed on the meeting and other things we find interesting. Thank you.